So more than 1,000 leadership studies have failed to produce the profile of an ideal leader. A study of 125 leaders recently showed you're not born with it, and you can't develop specific characteristics or traits, skills or styles of a leader that will guarantee success. I now cringe at some of the leadership talks I've given in the past, and I've very eloquently talked about the need for drive, integrity, motivation, self-confidence, insight, knowledge of the business, and emotional intelligence, which are probably all true, but that's not really what it's about. I've also talked about the need for a first follower. I don't know if you've seen this video, but he's the leader. And there's that first follower, and very soon, thanks to the first follower, but also actually thanks to the leader, there was quite a significant movement. Being yourself is essential, otherwise you're going to get caught out. So authentic leadership emerges from your life story and values. Although my life story and leadership journey aren't extraordinary, I've been asked to recount it, and perhaps there'll be a few lessons along the way. I was really lucky that Martin Snedden started with the need to tell a story. So I wasn't certainly a leader at school, and don't worry, I'm not going to tell you all about my childhood, but being producer of a medical review as a third-year med student called Humorous was probably my earliest leadership memory, and then there were a few as an RMO and anaesthetic SHO. In 1990 I came home from England and I had a baby boy and bought my own solo general practice. Over the next 10 years or so it became a 5-doctor general practice, and I had to lead a team who helped me look after my patients. I didn't lead the whole practice and I had no desire to. I also didn't want to keep expanding or working in general practice. I started to get interested in larger system issues and the bigger picture. Some of those system issues were intensely frustrating to me around the care of my patients and their access to hospital services. And I realised I needed to get involved in the system if I was going to achieve any change. After I did some research on GP referrals in 2000, I was offered a role. I think I did have an interview, working as a primary care advisor and GP liaison. So I sold my practice, moved over to the dark side. Someone warned me that the thing I'll miss the most is my patients and the fact that they were always thanking me, loving me and being grateful. And you move to everyone blaming you and being angry. It wasn't quite that bad, but one quickly learns management and leadership roles that it's impossible to please everyone all the time, and you need to grow a pretty tough outer layer. But better than a tough skin is having resilience. So life can make you strong and resilient. For me, it was a number of health challenges: tuberculosis in my first year of general practice, hemorrhagic dengue fever at the Commonwealth Games in Kuala Lumpur, and I got to see some of this, but the rest of it I was unconscious for. Prostate cancer just prior to starting my role as a CEO, and last year a broken back. Marriage or relationship breakups, deaths of best friends and family, these aren't extraordinary. But they all build character, both also keep work problems and challenges in perspective. This is my wonderful children. I have left my wife out of there, but she's definitely around. At some stage, you have to want to lead. In my case, my first two significant leadership roles were by accident, and that's a common experience for clinicians, the role of the accidental leader. In 2002, a good friend of mine was unable to go to the Commonwealth Games in Manchester, so as the most experienced of the 4 doctors, I'd also been to the Sydney Olympics, I became the Chief Medical Officer. It was to be my last games as I gradually wound down my clinical roles, but I learnt a lot from having to think about other people rather than just myself, I'm good at that, and having to work for someone I really didn't like or respect, and that happens in leadership roles. About the same time, the chairman of the Whangarei IPA, which was the precursor of PHOs, resigned, and somehow I got the job without wanting it. These were tastes of leadership, and perhaps somewhere in my subconscious I wanted more. because not long after that I decided actually that I did want to be a CEO, and I actually wanted to be the CEO of Northland DHB. So this is another requirement for leadership. You can't keep being the accidental or reluctant leader. You need to want it and have the drive to get it. So for me, there was a lot of hard work and a 10-year plan. Actually, there wasn't any plan at all, but I like to say that. I was having some success in my roles as a GP liaison and primary care advisor, but was still doing a fair bit of clinical work, drug and alcohol medical officer, private geriatric hospital that I ran, and sports medicine. But I realised at some stage I'd have to learn some real management theory and reduce my clinical work. So if in doubt, do an MBA, and I did, and a fellowship in medical administration followed, which was very helpful. It required me to put myself virtually into the position of being a CEO in a difficult situation, or a chief medical officer. Once during my MBA, I was told I was Machiavellian, which came as a shock, as I thought it was a bit of a criticism, but it was because it implies being devious and calculating, doesn't it? But however, when you look into Machiavelli, it's kind of okay. He pondered whether it's better to be loved or feared. He concluded the answer was probably both, but because it was difficult to combine them both in a person, it's much safer to be feared than loved. So behavioural science is now weighing in, and in showing that Machiavelli had it partly right. When we judge others, especially our leaders, we look for two characteristics: how lovable they are, warmth, communion, trustworthiness, and how fearsome they are, strength and competence. Another huge lesson during my MBA was a 360 appraisal. I was shocked to find I wasn't actually as well regarded as I thought. Some team members felt I was too forceful with my own ideas, used my intellect to get my way, and being unaware and completely unreflective of the impact of others. This single lesson was probably more powerful for me than any other, and since then I've tried to change my approach and style, but clearly I'm a really slow learner, because just prior to applying for this current CEO role that I've got 4.5 years ago, I was told by my mentor that I needed to be warmer, that my task-driven approach meant that at times, and it had happened that very morning with my mentor, I was forgetting to share a personal moment or humour with the person I was speaking to before launching into a discussion. And that reminds me that building those strong relationships at a personal level are essential. Quote Martin Snedden. Otherwise, the MBA was mainly a stepping stone, and while completing it, I took some accumulated annual leave. As an SMO, you get heaps of annual leave. And sorry, I really didn't mean to say that. To also work at Counties Manukau DHB as the primary care advisor for the National Meningococcal B vaccination program in 2003-04. One of the many MBA subjects was ethics, and I wrote an essay on the ethics of providing a $200 million meningococcal B vaccination campaign without addressing the cold chain, when we knew up to 16% of the vaccine would end up useless because most general practices stored their vaccine in domestic fridges where temperatures fluctuate wildly. I sent the paper to the senior Ministry of Health official, making it clear in the paper that whistleblowing was a last but very credible option. Needless to say, $4 million was found to purchase about 1,200 commercial vaccine fridges for every general practice in New Zealand as part of a cold chain accreditation program, which is actually a very clever way to ensure ongoing good practice. So, I guess I was acting a bit like a consumer in that situation, but I was terribly worried. After getting a whole lot more letters after my name, I moved from Whangarei to Wellington, took up my first general manager role, Director of Planning and Funding at Capital & Coast DHB. I'd never managed anyone, and suddenly I had a team of 50 and a budget of $750 million. Fortunately, I am a big proponent of the see one, do one, teach one, and things went okay. But at times, I'd find there were just too many issues to deal with. And for me, it was helpful to imagine that I was in one of these, looking over the problem, and then I would decide what I could do, and fortunately, because I was in this leadership role, what I could delegate for others to do the rest. So Wellington was also a great learning environment. We were building a $400 million hospital we couldn't afford, had been found and breached for the first time in New Zealand by the HDC, were unable to provide a paediatric oncology service, tried to privatise district nursing, fought to get a third linear accelerator that we needed but also couldn't afford, and my boss, who I had a huge amount of respect for, resigned suddenly. All of this while dealing with, and please again excuse me, a Wellington public who are either wanting to be politicians and bureaucrats, are politicians and bureaucrats, or worst of all, are retired politicians and bureaucrats. So tough times, and I was away from my 3 teenage children, missing out on really significant milestones such as my son's head boy speech. Probably one of the strongest leadership traits, which can also be a weakness for me, is that I'm an ideas person, have a very clear vision of where we want to go, and more importantly, why. Giving teams a sense of purpose and answering the critical question why is vital if you want to lead. So Simon Sinek says that rather than stating what we do, we need to talk about why we do it, how we do it, and then the what will follow. Apple don't say we make great computers, and they actually do. They say everything we do, we believe in challenging the status quo. We believe in thinking differently. The way we challenge the status quo is to make our products beautifully designed, simple to use, and user-friendly. And we just happen to make great computers. Or Harley-Davidson, their why is freedom. And actually, I studied them during my MBA, and by the end of that, I wanted to buy a Harley, and I hate motorcycles. And of course, there was Martin's earlier why around a stadium of 4 million. Somehow we have to ensure our vision is shared. I recall going to a GP conference in Hokianga and me failing dismally to convince Northland GPs that the map of medicine and clinical pathways were the way to go. I said it like that. Boy, have I got a deal for you, and talked about the what. Clearly didn't engage or inspire them at all. Of course, 4 years on, we're now implementing a Northland version of the Canterbury pathways. The response is quite different, and it's really about improving patient care and making their job easier. Our organisation's sense of purpose has been reinforced by our Northland Health Services Plan, a plan based on a triple aim. It's a 5-year plan with a 20-year horizon. It's bold headline targets such as by 2017 we want to reduce the life expectancy gap between non-Māori and Māori by 2 years and reduce avoidable admissions by 2,000 per year, and a number of others. It focuses on 5 key projects: Fit for Life, First 2,000 Days, Neighbourhood Healthcare Homes, Patient and whānau-centred care, and Urgent Healthcare. It's a very innovative plan, but there's actually nothing unique in it. This is the guy who said, "I have a dream." He didn't say, "I have a plan." Another clear sense of purpose occurred in 2013. We'd been found in breach a number of times by the HDC, and after commissioning an external patient safety and quality improvement review, we've been implementing its 75 recommendations. Making it explicit that patient safety and high quality care is number one is a very powerful leadership message. Leading in tough times is also vitally important. Fronting up and being accountable, even when it's not your fault, and working with your teams to solve those really wicked problems is a huge opportunity to make a difference, but also build credibility with your team and organisation. So I'll tell you about 2012, which was probably my toughest year. I'd just been appointed CEO, and we had to complete a mass meningococcal C vaccination campaign following an official outbreak in late 2011. This outbreak wouldn't have occurred probably almost anywhere else in New Zealand. It needed the perfect mix of economic and social inequalities. It became very public with a young man, Ben Brown, being sent home from our ED and returning the next day to eventually die in our intensive care unit. We spent over $3 million vaccinating 32,000 children and under 20-year-olds in a 10-week period. and we had to source the vaccine from all over the world, and I remember ringing pharmaceutical agencies all over the world to do that. Rather than having my clinicians have to front the coroner's inquiry into Ben's care, I spent the day in court apologising to the family on behalf of the organisation. Then May 2012 was the start of a terrible few months. Over the rest of that year, we had 19 youth suicides as young as 10. Social media played its part, but the common stories were being Māori, family violence, abuse, alcohol and drug use in the family, poverty, school truancy and loss of hope. Almost all of them died by hanging. So you can see 2012 in the red bars there. This emergent tragedy galvanised all of our social agency leaders and our Māori iwi leaders. We established our social wellbeing governance group, and I co-chair that, and also a fusion group where all intelligence about at-risk youth and their families was shared. We completely ignored some of the rules around patient privacy. And from there, mental health teams, police and school teams were rapidly deployed. We worked with the local communities at risk, providing formal training so that they could respond appropriately, and we ran plays which reached over 6,000 young people in schools and alternative education facilities. This is where loss of hope, suicide, regaining hope and resilience were carefully explored and discussed. We'll never know how much all of these actions contributed to our now very low youth suicide rate, but at the time I know that many lives were saved. Innovation doesn't always come in the form of a shiny new iPad. I've been told that sometimes I bring clarity and simplicity, well, I've been told it once, to a difficult problem. This is something leaders do, and it probably comes from having all the information, keeping that helicopter view and being pretty simple people. It's a fine balance, but being visible and yet ensuring that it's not all about you. All of my failures have come from believing I can do it on my own and not working with a team which includes or is pretty much totally about clinical leaders. Very little in health, if anything, can be achieved without clinical leadership. I've also known how important it is to have a great team around me. They've always made me look good, and through their leadership, most of the work gets done. But a few years ago, my CMO pointed out to me that recruiting a new senior medical officer, especially if they're young, is at least a $10 million investment. And up until about 4 years ago, these appointments were made following an interview with the clinical director, sometimes on the phone, and a few reference checks. Now, every senior medical officer appointment is made with a panel of at least the CMO, general manager, and clinical director, and we're introducing values-based screening and interviewing. The same rigour extends to our recruitment of clinical leaders. All clinical leadership roles are advertised internally, and if we're not happy with the applicants, in some occasions don't have any, we will advertise externally. We no longer offer the beach lifestyle, rather it's about a great place to work with a work-life balance. We now hire people who believe what we believe. They'll work with blood, literally, if they're surgeons, sweat and tears, rather than just for the paycheck and lifestyle. One also needs to acknowledge that recruitment's actually a competitive sport, and we'll recruit as aggressively as we can. Some of our best clinical leadership recruitments have been through our clinicians, knowing clinicians in another place, knowing that is satisfied and convincing them to move. Then it's actually a matter of nurturing and supporting these leaders to ensure they stay. So where next? Having a few good leaders and clinical leaders is not enough to get a movement going or shift a culture. We need an organisation that's attractive to younger, innovative, creative employees, our next leaders, that lives the organisation's values. We also need a workforce that matches our population. So in Northland, we've got 33% of our population who are Māori, and only 4% of our doctors are Māori. It's similar for nurses and most of our allied health professions. We need more Māori who can lead or willing to lead, and we are actively recruiting Māori and providing scholarships and work shadowing and other opportunities. People like Lance OSullivan, who have incredible passion, energy and innovation, who aren't satisfied with the status quo and want to change the world for the better. That's who we need. However, recruiting isn't enough. We need to train and support all our staff to lead We need collective leadership. Collective leadership means everyone, and I think ASMS calls this more distributive leadership, but I really like the term collective, means everyone taking responsibility for the success of the organisation as a whole, not just for their own jobs or even their work area. This contrasts with traditional approaches to leadership, which have focused on developing individual capability while neglecting the need for developing collective capability. We've run a leadership program for the last 3 years for 20 to 25 talented clinicians and managers, which runs over a whole year. But on its own, it won't be enough. It will take forever to get to that tipping point for change, whatever that is, maybe 15% of the workforce. Collective leadership cultures are characterised by all staff adopting leadership roles, focusing on continual learning and through this on the improvement of patient care. I've been acutely aware that all the quotes that I've been displaying, and you might have noticed it particularly if you're a woman, come from old men or men that are dead. So I'm going to end with a quote from a woman. Ironically, it was attributed to a man. The following passage was attributed to Nelson Mandela, but actually came from Marianne Williamson a few years before Mandela's famous acceptance speech. Our deepest fear is that we are inadequate. It's not that we're inadequate. Our deepest fear is that we are powerful beyond measure. It's our light, not our darkness, that most frightens us. We ask ourselves, who am I to be brilliant, gorgeous, talented, fabulous? Actually, who are you not to be? As we let our light shine, we unconsciously give other people permission to do the same. As we are liberated from our own fear, our presence automatically liberates others. And finally, just another reminder of the power of our patience and whānau. And I want to acknowledge we've got really similar ideas, obviously clearly very good ideas. Thank you all very much.